just wanted to say thank you to you, Dr. Kairam, and also to Dr. Gundapalli, who is my colleague at Baylor College of Medicine here in Houston, Texas, in the United States. I also wanted to thank Dr. Sudhakar as well, and everybody for attending this presentation. So thank you all very much. I hope you find it helpful. And I'm trying to give a very up-to-date summary of where we stand currently on treatment of COVID-19. And in addition, Dr. Kairam asked me to address many questions that had come from the group. So feel free to put the questions in the chat. Dr. Kairam will ask the questions as we're going in the presentation. So I'm happy to take any questions. And also these slides, PowerPoint slides, which I have made, I will share with Dr. Kairam at the end of this session, and perhaps he can distribute to everybody so that everybody can have access to these slides. So this information will be available after the presentation.
Thank you.
And finally, just before I start, in case anybody is online and is on Twitter, which is very similar to Facebook, there's actually a lot of medical information on there about COVID-19, about many things in infectious disease and medicine in general. You feel free to follow me there. I post a lot of information about COVID, about infectious disease, about many things. And you can follow many famous people are also on Twitter. You can follow them along. They post a lot of useful information, and it's publicly available. This is just a slide showing my disclosures where I get funding for research. So the objectives of this evening's or this morning's presentation for you all in India is the following. Review the pharmacological treatment approaches for COVID-19 based upon illness severity. Review the role of antibiotics in the treatment of COVID-19. Review the role of anticoagulation in the management of patients with COVID. And finally, provide a brief overview of approach to diagnosis and management of mucormycosis because of everything that's going on right now in India. As I mentioned last time, for those who are here, I'm originally from Pune in Maharashtra, and I have many relatives who I know who have had COVID-19, and so I know it's quite a very serious situation over there. So I hope this presentation is helpful for everybody. The two main resources which I am using, or references which I am using for this presentation, are the following. One is at the top, which is from the Infectious Disease Society of America, which are guidelines on the treatment of management of patients with COVID-19. And at the bottom are treatment guidelines for COVID-19 from the US National Institutes of Health. Both of these guidelines are updated regularly and are very helpful and what most of us are using for managing COVID-19 patients in the United States. In terms of categories of COVID-19, there are 5 categories. I'm sure everybody in the audience knows this: asymptomatic, mild, moderate, severe, and critical. And we're going to go over the treatment for each of these based upon the illness severity of the patient. I want to make one comment about these particular treatments. The ones you see on the left-hand side of your screen: hydroxychloroquine and chloroquine, azithromycin, ivermectin, convalescent plasma, vitamin D, zinc, and aspirin. All of these medicines have been studied in some form or fashion, and currently they have no role in the prevention or treatment of COVID-19, regardless of illness severity, mild, moderate, severe, critical. At any stage, none of these medicines have as yet been proven effective for treatment of COVID-19. So in general, we have been avoiding these medications because they either don't show any benefit or in some cases show harm. None of these medicines currently have any benefit, and we're not using them in the United States. I wanted to show everybody this update. It was just released literally 12 hours ago. from the United Kingdom based upon their trial, which they're running there, called the recovery trial. And in the recovery trial in the UK, they did a randomized controlled trial of patients with COVID-19 utilizing aspirin for treatment. They had almost 3,000 patients in the study, and they used a dose of 150 milligrams of aspirin. And in their trial, aspirin did not show any improvement in survival for patients hospitalized with COVID-19. They did an excellent study, very good. This was just released 12 hours ago online, and it showed that aspirin was not shown to be of any benefit in patients with COVID-19. So unfortunately, that's another medicine which will not work for COVID-19. I also wanted to make one comment on a new medication, which many people may be familiar with, called 2-DG, or 2-deoxy-D-glucose. So this was approved by the Drugs Controller General of India on 1st May, just 1 month back, as emergency authorization. However, they quote data from a phase 3 clinical trial, but that trial is not yet published in the medical literature. It's not available currently. There is some information based on news reports, but the scientific publication is not available currently. So at this moment, right now, June 8th, 2021, it's not currently, 2-DG is not recommended by Infectious Disease Society of America, US Centers for Disease Control and Prevention, or the World Health Organization. If their trial gets published and we can review the data, then maybe it's possible that 2-DG may be recommended. But right now, that information is not publicly available. And there's no published evidence showing that 2-DG is effective. At least right now, it's not available, despite the fact that it has an authorization in India. Okay, shifting gears to asymptomatic COVID-19. The only recommended approach for patients who are asymptomatic is to monitor for development of symptoms. There's no indication for any prophylactic or therapeutic medication if a patient is entirely asymptomatic. In terms of mild and moderate COVID-19, the definition of mild COVID-19 is a patient who has any single sign or symptom of COVID-19 that does not include shortness of breath. And if chest imaging is available, this is normal. Moderate disease is any patient who has any evidence of lower respiratory tract disease, basically pneumonia, either by clinical assessment, meaning the patient may have shortness of breath, or rales or crackles or something like this, or by chest imaging, meaning chest x-ray or chest CT if it's available. And if it's been taken, the oxygen saturation should be greater than 94% while the patient's breathing ambient air. So these are the definitions of mild and moderate COVID. So what is the management of patients with mild and moderate COVID-19, meaning the patient is not in the hospital? So of course you can use symptomatic therapy with antipyretics, antitussive medications as needed. Also okay to use paracetamol or non-steroidal anti-inflammatory drugs as well. Basically, symptomatic treatment is fine. In terms of specific medications for mild to moderate COVID-19, again, patient is at home, not hospitalized. Monoclonal antibody therapy has been shown to provide mortality benefit, meaning it saves patients' lives to give monoclonal antibody therapy, not convalescent plasma, monoclonal antibody therapy. The two main options for this are two antibodies made by Eli Lilly and two others made by a company called Regeneron. I believe in India, what is available is the first one, bamlanivimab plus etesevimab. That's a monoclonal antibody cocktail, which has shown mortality benefit in patients with mild to moderate COVID. I just want to mention that just 2 weeks ago, May 26, 2021, a third monoclonal antibody was approved in the United States for treatment of mild to moderate COVID. That's a new antibody called sotrovimab. I don't think it's available in the United States, but I wanted to, in India, but I wanted to let you know that a third monoclonal antibody has been approved now in the United States as of 2 weeks ago. And just as a reminder, I'm sure everybody knows this, but I think it's helpful to review. Convalescent plasma is made up of polyclonal antibodies, meaning many different types of antibodies targeting many different epitopes. A monoclonal antibody is, of course, one specific type of antibody that's targeting one specific antigen on the spike protein. A monoclonal antibody cocktail is two specific monoclonal antibodies, again, targeting specific antigens, specific epitopes on the virus. So who should get monoclonal antibody therapy? It should only be patients who are at high risk for progression to severe COVID. So the people who should get monoclonal antibody therapy are patients who have mild or moderate COVID-19 at home. They're not yet in the hospital, and they're at high risk for progressing to severe disease because they are either older than age 65 or they have underlying medical conditions such as diabetes, heart disease, lung disease, kidney failure, etc. Those are patients who should get monoclonal antibody therapy. If somebody is below age 50, has no medical problems, that patient probably does not need monoclonal antibody therapy. It's meant for patients who have high risk for progressing to severe COVID. So I'm not going to read all of this chart. I will send these, as I mentioned, I will send these slides to Dr. Kairam. He can send to everybody. But basically, it should only be high-risk patients who get monoclonal antibody therapy. Again, usually above the age of 65, or they have kidney disease, diabetes, some other kind of medical problem. There's been a lot of talk about inhaled budesonide, which is an inhaled corticosteroid for use for treatment of mild to moderate COVID-19 at home. To date, there is only one randomized controlled trial evaluating inhaled budesonide for treatment of mild to moderate COVID-19. It was published in one of the Lancet journals in the United Kingdom about 1 month back. I showed it there. You can find it on the internet. It's available. And it was a small study, only less than 150 patients. Phase 2 trial, not a phase 3 trial, phase 2 trial. And it was not very large trial. And it was okay as a trial, but it was not so strong. So just 1 week back, 2 weeks back, the European Medicine Agency from Europe recommended not to use inhaled budesonide for mild to moderate COVID-19 because the data are insufficient. We do not have a large randomized controlled trial showing the efficacy of inhaled budesonide. We only have a small phase 2 trial. So again, based on this, it was not recommended in Europe, and it's also currently not recommended in the United States either. Okay, so that's mild to moderate COVID-19. Now I'm going to shift to severe or critical COVID-19, meaning hospitalized patients. Again, this is the definition of severe COVID-19. Severe COVID-19 is any of the following. Patient has an oxygen saturation less than 93%. Respiratory rate is greater than 30. Their PaO2 over FiO2 ratio is less than 300. And by chest imaging, their lung infiltrates are greater than 50% on chest X-ray or chest CT. The definition of critical COVID-19 is any of the following, any one of the following: respiratory failure, septic shock, or multi-organ dysfunction. These are the definitions of severe and critical. So what is the management of patients with severe or critical COVID-19? First, most important medication, which has the best mortality benefit for severe or critical COVID-19 is dexamethasone. Remdesivir may decrease the time of hospitalization, but it has not been shown to improve mortality, meaning the patients may not be more likely to live longer, but if they survive, they're likely to be in the hospital less days. So in my mind, most important, number one, is dexamethasone. Less than that important is remdesivir. And in fact, the World Health Organization, WHO, does not even recommend remdesivir. In the United States, we recommend it. But dexamethasone has much better mortality benefit. In terms of monoclonal antibodies, the ones we discussed previously, they have no role in the treatment of patients hospitalized with COVID-19. Monoclonal antibody therapy should be used for patients with mild to moderate COVID who are outpatients, not yet in the hospital. By the time they get in the hospital, it's too late. Already, the body has already made antibodies, and it's not enough to stop the patient from progressing. So if the patient's already in the hospital, monoclonal antibody therapy has not been shown to be effective. It's most effective when it's given for mild or moderate COVID as outpatient. Few important points about dexamethasone. Dr. Kairam asked me, can you review these points about dexamethasone? First, the dosing of dexamethasone is 6 milligrams IV, intravenous, or by mouth once per day. Maximum duration is 10 days. If patient is discharged from the hospital before 10 days, there's no need to prescribe dexamethasone at the time of discharge. So the large trial that was conducted in the United Kingdom, recovery trial, in that trial, dexamethasone was given for maximum 10 days, or if the patient was discharged from the hospital, they stopped dexamethasone. If the patient is discharged, they don't need dexamethasone at home after that. There's also no need for a prolonged taper after 10 days of steroids. If you finish 10 days, patient's doing better, there's no need to taper dexamethasone. There's also no role for systemic steroids, meaning oral steroids, for mild or moderate COVID-19. So if patients at home, they're not yet in the hospital, oxygen saturation is above 93, 94, there's no need to prescribe dexamethasone at home. And I'll show you why in a couple of slides, but dexamethasone should be reserved for patients in the hospital. There are possibly some situations where steroids could be longer than 10 days, but this is not the standard recommendation. This is the major study which evaluated dexamethasone in the hospital. It's from the United Kingdom. The trial is called the Recovery Trial. It was published in New England Journal of Medicine in July of 2020, almost 1 year back. This is the main result from that study. And what I want to draw your attention to is these 3 lines. The most benefit, if you see my mouse there, the most benefit of dexamethasone is in patients who are on invasive mechanical ventilation, meaning intubated in the hospital. There was some benefit for patients who are on oxygen. But if you look, what I've circled here, patients who are not on any oxygen, meaning they did not have hypoxemia, they're not on oxygen. In fact, they had a little bit of tendency towards harm instead of benefit. So what data we have suggests that patients not on oxygen, in fact, do a little bit worse with dexamethasone than better. So because of that, dexamethasone is not recommended for people who are not on oxygen. Okay, I want to shift gears now to tocilizumab, which is an anti-interleukin 6 receptor monoclonal antibody. These are 5 studies which were published from September to December 2020. 5 studies on tocilizumab. And all 5 of these studies showed no benefit of tocilizumab. However, in last 2 months, 2 new studies have been published. First was from United States, published in New England Journal in April. Second was from a recovery trial in United Kingdom, published in Lancet in May 2021. Both of these trials were excellent. And in particular, the recovery trial had almost 3,000 patients in this trial. And these 2 trials, unlike the prior 5 trials, these showed mortality benefit from tocilizumab. Let me show you the next slide. So when to use tocilizumab? Because as I told you, these 5 trials showed no benefit, but these 2 trials showed mortality benefit. Now, why is that? The reason is, in these 5 trials, tocilizumab was used in patients who were already in the ICU for several days. In these trials, the ones that showed a benefit, tocilizumab was used earlier. It was used sooner. If you use tocilizumab in too early, it's not going to be of benefit. If you use tocilizumab too late, it's also not going to be of benefit. Patient is already too sick. You have to use tocilizumab in the middle. When patient is in the hospital, they're getting worse. They're not yet intubated. They're not in the ICU, but they're getting worse. As you're seeing them every day, their oxygen is going up. Everything is going in the wrong direction. That's the time to use tocilizumab. So this is when I use tocilizumab if I'm seeing COVID patients. Patient who has severe critical COVID-19, as per the criteria I showed before, the patient is getting worse, progressively worsening. There's evidence of systemic inflammation as shown by laboratory testing, usually a CRP, C-reactive protein, greater than 7.5 milligrams per deciliter. If you use milligrams per liter, it's 75. Within 24 hours of admission to the ICU. So ideally, it's a patient who's getting sick and they go in the ICU and immediately you should use tocilizumab. That's the time to use tocilizumab. If you use too early, it won't benefit. If you use too late, also it won't benefit. You have to use it in this middle zone. So for mild to moderate disease, it's not needed. Much later in the course, many days after the patient is in the ICU, it probably won't be effective because it's too late. Okay, let me shift now to another medication, which many people may have heard about, called baricitinib, which is a Janus kinase or JAK inhibitor. This is the trial that evaluated baricitinib. It was published in New England Journal in December of 2020. It was a randomized, double-blind, placebo-controlled trial evaluating baricitinib plus remdesivir versus remdesivir plus placebo. It had 1,000 patients. And in fact, it was shown that the combination therapy of baricitinib plus remdesivir was superior to remdesivir alone, especially in patients on high flow oxygen or non-invasive ventilation like BiPAP. However, almost 200 patients in this trial received steroids. Therefore, this is the recommendation from Infectious Disease Society of America. Among patients hospitalized with severe COVID-19 who cannot receive corticosteroids, then you can consider to give baricitinib. So when I use baricitinib is, patient comes in the hospital. I want to give them dexamethasone. I want to give them remdesivir. That's a typical, I give every patient remdesivir or dexamethasone. For some reason, patient cannot get dexamethasone. There's some problem. The sugars are out of control. So some other issue, I cannot give dexamethasone. Then I will use baricitinib. I only use baricitinib if I cannot give the patient dexamethasone. Also, just so you're aware, in the United States, they were running a trial to compare remdesivir plus dexamethasone versus remdesivir plus baricitinib to see which one is better. And in fact, in this trial, as you see here, in April 15th, National Institutes of Health closed this trial because there was no benefit from remdesivir plus baricitinib compared to remdesivir plus dexamethasone. So bottom line is the following. Patients admitted to the hospital, I will give dexamethasone plus remdesivir. I only use baricitinib if I cannot give dexamethasone for some reason. Okay, let me shift gears now to antibiotics. There's no indication for routine antibiotics for patients who have confirmed COVID-19. You do not need to give routine anything. If for some reason you suspect, truly suspect bacterial superinfection, as the patient's in the hospital, you can maybe think about giving antibiotics. But routine antibiotics is not needed for patients with COVID-19. I want to shift now to anticoagulation. There's no indication for empiric therapeutic dose anticoagulation for patients with COVID-19. What I mean by therapeutic dose means high dose that you would use to treat venous thromboembolism. There's no indication for therapeutic dose anticoagulation. In fact, there was a big trial published just 2 months back in the journal JAMA, evaluated empiric therapeutic anticoagulation for patients in ICU with COVID-19. There was no benefit on mortality, no benefit at all. So the evidence does not support therapeutic dose anticoagulation for patients with COVID-19 empirically. You should use standard prophylactic dose anticoagulation for patients admitted to the hospital, either heparin, low molecular weight heparin. So when should somebody get therapeutic dose anticoagulation? You should only use therapeutic dose anticoagulation when the patient has proven venous thromboembolism and not simply D-dimer level is elevated. That's not sufficient. You should prove thromboembolism or some other standard indication for therapeutic anticoagulation, such as atrial fibrillation, a mechanical heart valve, or they previously had venous thromboembolism. These are the reasons to give therapeutic anticoagulation. Otherwise, empirically, for all patients, it's not recommended. And there's a large randomized controlled trial to back up that recommendation. So in summary, for outpatients with mild to moderate COVID-19 who are at high risk for progressing to severe disease, the options for treatment are any of the monoclonal antibodies, all as a one-time infusion. Again, only for patients who have mild to moderate disease at home, and only for patients who are at high risk for progressing to severe disease, either because they're older or they have medical comorbidities. Also, avoid the use of corticosteroids for patients with mild to moderate COVID-19 at home. There's also no routine need for a prolonged taper or treatment beyond 10 days. For patients who are hospitalized with severe or critical COVID-19, including patients who have an oxygen saturation less than 94%, you should definitely use dexamethasone once they're in the hospital and hypoxemic. Consider remdesivir. If the patient is unable to get corticosteroids, you can use baricitinib. And for hospitalized patients with progressive, severe, or critical COVID-19 with elevated biochemical markers of systemic inflammation, such as CRP, C-reactive protein, you can use one-time dose of tocilizumab on top of steroids if the patient's in the hospital and they are getting worse and they have systemic evidence of inflammation. There's no indication for use of monoclonal antibodies once a patient is hospitalized with COVID-19. It should only be used in the outpatient, because once they're hospitalized, it's too late. There's no role for routine antibiotics, therapeutic anticoagulation, or aspirin in treatment of COVID-19, not routinely. You should use normal prophylactic doses of anticoagulation for hospitalized patients, including those in ICU. Okay, I'm going to change gears now from COVID-19. I have a few slides on mucormycosis, and then I will stop and I'll take any questions from the chat. This was an excellent review article just published 1 month back. I put the reference on the slide there. As I said, I will share these slides. The reference is on the slides there. This is an excellent 5-page, very nice summary, mucormycosis. I highly recommend everybody read this summary. It's a very nice summary. The term mucormycosis refers to a group of filamentous fungi, pure molds, in the order Mucorales. The most common species are Rhizopus mucor and Rhizomucor. These fungi are found everywhere, including soil and compost. Traditionally, the main risk factor for rhino-orbital cerebral mucormycosis was diabetes, and in particular, diabetic ketoacidosis. Recently, immunocompromised patients also are at significantly higher risk, including those with hematologic malignancies, stem cell transplant, or solid organ transplants. Also, other situations where mucormycosis has been diagnosed include trauma, meaning some accident, injury, something like that, natural disasters, such as hurricanes, cyclones, those things, or there are some rare instances of healthcare-associated outbreaks from infected materials, infected supplies. It's quite rare, but it has been reported. This is a typical presentation of rhino-orbital cerebral infection. It occurs when spores are inhaled into the sinuses. It's the most frequent presentation in patients with hyperglycemia and especially with diabetic ketoacidosis. Of course, everyone knows the common symptoms: fever, headache, sinus pain, nasal congestion. It can extend into the central nervous system and cause vision loss, cranial nerve pathology. And the mortality rate can be quite high, anywhere from 25 to over 50%. Other types of clinical presentation of mucormycosis include pulmonary disease in the lungs, as you see on the CAT scan there, cutaneous disease, as you see on the picture on the right, and much more rarely, gastrointestinal disease, renal disease, and disseminated infection. So how to make the diagnosis? For definitive diagnosis, you require demonstration of wide Riemann-like non-septate hyphae on tissue histopathology and also growth of fungi on clinical specimens. However, sometimes these fungi are difficult to grow and they don't always grow in culture. So it can be difficult to make the diagnosis sometimes because they don't grow. But most important is, if you can get it, is histopathology. Very, very important. Some people are trying to utilize serum testing for diagnosis of mucormycosis, but it's very important to point out that the typical serum fungal tests, 1,3-beta-D-glucan and Aspergillus galactomannan, will be negative, are expected to be negative in patients with mucormycosis because the cell wall of Mucorales species don't have these molecules, don't have these components. So these tests will be negative in patients with mucormycosis. They should not be used to make a diagnosis. In terms of treatment for mucormycosis, the best agent is still amphotericin B. The options for amphotericin B include the original amphotericin B, which is amphotericin B deoxycholate, liposomal amphotericin B, which is called Ambizome. Finally, amphotericin B lipid complex, which is in the United States is called Abelset. There are two azoles which have activity against Mucorales species: posaconazole and isavuconazole. Both of these are available as oral and IV formulations as well. These are all medications which have no activity against Mucorales species. Voriconazole, itraconazole, fluconazole, no activity. Echinocandins, such as caspofungin, micafungin, anidulafungin, no activity. And also flucytosine. Although these are antifungal and they treat many other fungi, they have no activity against mucormycosis. And the duration of treatment, meaning how long should the patient be treated, is unknown. It varies from case to case, at least several months, sometimes for years, and sometimes for the rest of the patient's life, they have to take something for mucor. I'm not going to read all this. This is for your reference. It's a dosing chart for all formulations of amphotericin and posaconazole and isavuconazole. As I said, I will share these slides, but this is a dosing regimen for the effective antifungals. You must perform surgical debridement of all necrotic tissue. I think many people know this. It's especially needed for rhino-orbital cerebral mucor, and sometimes you must perform many surgeries repeatedly. There's also a medicine called deferasirox, which is an iron chelator. This medicine has not been shown to be beneficial in a randomized controlled trial of liposomal amphotericin B plus deferasirox versus liposomal amphotericin B plus placebo. So this medicine should not routinely be used for mucormycosis. Some people are using it, but there's really no evidence to support it. And finally, hyperbaric oxygen is sometimes also used. This is not routine and it has not been evaluated in a randomized controlled trial, but some people are using it. I personally have not used it very much, but some people are using it, but there's no strong data to support hyperbaric oxygen for treatment of mucormycosis. And that's the last slide. I thank you all very much for your attention. My email address is there. Anybody can email me any questions. As I said, I will share these slides with Dr. Kairam. Hopefully he can share with Dr. Sudhakar, share with everybody. So they'll be available. But if you have any questions, please feel free to send me an email. I will try to answer the email as well. I will stop sharing my screen and then I'm happy to answer any questions that came in the chat.
That is very nice, Dr. Kulkarni. I wish if we had this kind of information 6 weeks ago, 5 weeks ago, many patients that were given excess drugs, unnecessary drugs, too many drugs, too early steroids, too much steroid, too long steroids might have been reduced. But we did not know you at that time. Thank you. I do want to look at the questions in the chat box, but I have one burning question. It's not really related to pharmacology. Sometimes drugs are given for other reasons. So I was struck with the sentence that you said, who should get monoclonal antibody? Those that are at high risk for progressive disease. Let's assume the monoclonal antibodies work well for those that are at high risk for progressive disease and above 65. And if cost is no factor, and if availability is no factor, why wouldn't you give it to a 55-year-old who's willing to buy?
Yeah, good question, Dr. Kairam. You can give it. If cost and availability is not an issue, probably it would be okay to give. I will say the most benefit was seen in the patients who are at high risk. So I guess I would say it probably won't hurt a 40-year-old healthy patient to get it. Probably won't hurt. But the question is it really going to help that much for a young, healthy person who statistically, they're probably going to be fine anyway, even if they get no treatment. Compared to somebody who's 75 years old, their outcome is, quite possibly going to be very bad. Compared to a 35-year-old, even if they get nothing, probably they will be fine. So bottom line is it probably won't hurt. I'm not so sure it's going to add so much benefit to them. And then just keep in mind, some very small fraction of patients can have an infusion reaction to monoclonal antibody therapy. So you have to be a little bit careful. You want to try to use it in the patients where you think it will have some benefit.
Okay. I saw several questions in the chat box. There may be one or two I might ask the questioner themselves. But otherwise, Dr. Anne asked an interesting question. We are discrediting the budesonide study since the number of patients in the study is only 300. At the same time, we're accepting the results of Blaze 1 study in which the number of patients is only 750 patients. Dr. Anne, before I pose that question to Dr. Kulkarni, I don't know these studies, but are all the other factors equal? Meaning the effect size in the design of the study itself, is it equal? Are you only raising the issue 300 versus 750? Is that something you can clarify before we ask Dr. Kulkarni to answer, or you both already know this discussion from before? Are you there, Dr. Anne? Okay. Dr. Kulkarni, go ahead and answer that.
Sure. Yes. Okay. Let me talk about that. So the inhaled budesonide study was a relatively smaller study. It was phase 2, and it's not a bad study. It's just a little bit underpowered. And then the other thing is that if you look, I reviewed the study today. The primary endpoint in that study is progression to being evaluated in the emergency department. The primary endpoint of that study was not mortality benefit, which is really the main thing we want. We don't want people to die from COVID or get severe COVID. The primary endpoint in that study was that you had to go to an emergency department for evaluation. So, I'm not so sure the endpoint was as clinically meaningful as we want. And number two, the size was small. Now, in reference to the monoclonal antibody studies, which were mentioned, Dr. Ane is absolutely correct that BLAZE-1 study was not so powerful. However, the emergency use authorization for the monoclonal antibodies therapies for outpatients with mild to moderate COVID was not based on BLAZE-1 study. It was actually based on BLAZE-3 or BLAZE-4 study, which was a large randomized controlled trial, approximately 1,000 patients. And in that study, the primary endpoints were mortality and progression to hospitalization. And in that study, with 1,000 patients, well-designed, very powerful study, the number of patients who died from COVID, who got monoclonal antibody therapy was, I think in BLAZE-4 was 0. And the number of patients who got hospitalized was very low. So there was a significant reduction in deaths and hospitalizations in a much bigger study with much more power. So I think that, if I'm not mistaken, that was BLAZE-3 or BLAZE-4 for bamlanivimab plus etesevimab. So I think there's some significant differences in those trials. I think inhaled budesonide is maybe possible. I would like to see a large phase 3 study for inhaled budesonide. And if that comes out and it shows a benefit, I will use it myself. But right now, I haven't seen any other data other than that one trial.
Okay. Dr. Ane had another question. What is the rationale of using remdesivir when it is reducing only 2 days of hospitalization with no reduction of mortality?
Kairam, could you ask Kairam, could you ask somebody to unmute Dr. Ane? I think he's having trouble unmuting.
Okay, it's unmuted now. If it's only 2 days of hospitalization with no reduction of mortality, can the population of India be placed on this economic burden considering the cost of this drug? But before you proceed with the answer, is it 2 days or 4 days of hospitalization?
Yeah, it's 4 days actually. It's difference is 11 days if you get remdesivir, 15 days if you don't get remdesivir. So difference is 4 days. But Dr. Ane's point is very good, meaning it may be very expensive. There's no mortality benefit that's been demonstrated. And in fact, as I mentioned briefly in the talk, the World Health Organization, WHO, does not routinely recommend remdesivir. In the United States, we're recommending it. But WHO says that, there's no mortality benefit. Why do you use remdesivir if it's expensive, number one? And number two, there's no mortality benefit. So Dr. Ane's point is very good, meaning if somebody chooses not to use remdesivir, I think that's probably okay. In my mind, the most important drug for a hospitalized patient is dexamethasone. And then maybe if the patient's getting worse, 1 dose of tocilizumab. But I agree with Dr. Ane. Yeah, if you want to use remdesivir, I think it's okay. I don't think it's routinely required. I think there are more important things you can do, especially if cost is prohibitive.
Okay. Dr. Gopi asked the question, can you tell us more about the combination of monoclonal antibodies in the treatment of mild to moderate?
Yes, again, the best place to use monoclonal antibody therapy is for patients with mild to moderate COVID as outpatients who are at high risk for progressing to severe COVID-19. Once you're in the hospital, it's probably too late. And if you're asymptomatic, I don't think it's needed. But if you're mild to moderate, you're at home, you're feeling bad, and you're at high risk, especially elderly population and anybody with diabetes, kidney disease, heart disease, anything like that, those are the patients to give monoclonal antibody therapy. Especially the cost is very high, and especially the supply is very limited. To me, those are the patients to use monoclonal antibody therapy. I wouldn't waste it on hospitalized patients. I would use it for high-risk outpatients who are having some mild, moderate symptoms.
Dr. Buddharaj, you have your hand up.
Yeah, I had a couple of questions on the monoclonal antibodies. So I haven't seen the Blaze 3 and 4 data, at least the published version yet. I don't know if I'm missing the publication, but I haven't seen that. Number one. Number two, I think the Blaze 3 had about 1,000 patients, but the current guidelines from the society seems to favor the Regeneron combination of casirivimab and imdevimab because of issues with resistance to some of the variants. And while issuing the EUA, emergency use authorization, the FDA specifically mentions clinicians should be watchful of local prevalence of variants. So having said that, we know that at least by FDA publication, they've mentioned that there's significant resistance to this with the South African strain. The UK strain seems to be susceptible to these monoclonal antibodies, both the Regeneron and the Lilly one. So we don't have any data on the Delta variant, and the FDA actually mentions that. They don't comment on the efficacy of monoclonal antibodies with the Delta variant. We know that these monoclonal antibodies target epitopes on the RBD, or receptor binding domain of the spike protein. So if that epitope happens to be the same, where there's a point mutation, for example, in a variant that's new, like Delta or the Vietnam variant or whatever. So unless the efficacy is proven with that kind of variant, I'm not sure we should come to a conclusion that these monoclonal antibodies are going to be showing the same kind of efficacy with the Delta variant, which is predominant in India right now. So I think currently, I don't know if it's part of a trial, but a lot of the private sector in India is already delivering, not the first one, the Regeneron compound marketed by Roche, the casirivimab is what I think is being given right now. So could you comment on that? And has that been an issue? Why did FDA issue that warning about being careful with prevalence of variants in the community?
Yeah. Thanks for a very, very good question, Dr. Budraju. You're exactly right. So let me just lay the background. There are two main monoclonal antibody cocktails. First is bamlanivimab plus etesevimab. That's an Eli Lilly product. The other one is casirivimab plus imdevimab, which is the Regeneron product. As you mentioned, both have emergency use authorization in the United States. The Eli Lilly product, they have put a warning not to use in 8 states out of 50 in the United States because of the problem of variants, and that these monoclonal antibody cocktails don't work well against those particular variants in those states. Now, some of those variants are predominantly in the United States, actually. There's a California variant, there's a New York variant. I'm sure you know all the, there's all these other variants that are actually just in the United States. And some of these monoclonal antibodies don't work well against some of the United States variants. The other comment I wanted to make was the Blaze 3 and Blaze 4 studies. You're right. They have not been published publicly, but if you read the summary of the data from FDA, upon which they gave the emergency use authorization, it's very good, the summary of their data. But you're right, the official publication has not come yet. You're right about that. Final point is, how good are the monoclonal antibodies against the Delta variant, meaning B.1617.2, which is in India right now? I don't think anybody knows the answer to that question, to be very honest, from a clinical standpoint. Because the studies that proved the efficacy of bamlanivimab plus etesevimab or casirivimab plus imdevimab predominantly were done in the United States before the emergence of the Delta variant in India. So you're right that there's some possibility they may not be as efficacious against the Delta variant. I'm not sure the truth is, I don't think we know 100%. The best would be to do another trial in India right now at the time when this particular variant is circulating. But you're correct. We don't have the data to know 100% for sure. I would say the trials that we do have are really very good. So I probably would still use them for that particular high-risk population in India. But I agree with you that there's a possibility of diminished efficacy in India. I agree with that.
Dr. Budarazu, we closed on that one for now. Dr. Faninder, you have a question. Unmute yourself, sir. Go ahead.
Yeah. So, good evening, sir. This is Dr. Faninder, pulmonologist. I am against the use of antibiotics until recently in COVID. But knowing this particular phenomenon going on with COVID clinical course in the evolution of the whole course of COVID and comparing to influenza virus, the influenza virus has a brief illness, and then following the influenza virus, there is a damage to the mucociliary blanket. The mucociliary escalator in the lungs is damaged, and hence secondary bacterial pneumonia follows. Secondary bacterial infections follow. So in this context, the influenza has a very brief illness, and the bacterial infections follow the influenza course. But as a matter of fact, when considering the COVID, it has a prolonged, a protracted course, like in the asymptomatic phase, the mild phase, or the moderate, or the critical. And the course is much prolonged, maybe 2 weeks, 3 weeks later. So in this accord, they have observations that it's always a combination of a viral phenomenon going on and the bacterial superinfections on this clinical course of the evolution of COVID. So to this extent, my question is how to approach and detect a probable bacterial superinfection at every stage of the evolving COVID disease. And what could be the best means of clinical and laboratory assessment of this, and try to approach for a proper antibiotic.
Yes, thank you for this question, Dr. Fernanda. It's a very difficult problem. Okay. Let me just give one background information. There have been few studies, or I would say several studies on co-infection with COVID. And most estimates right now are roughly 5 to 10%, maybe something around that. 5 to 10% of patients with COVID have bacterial superinfection, roughly, depending on which study you look at, 5 to 10%. Okay, so it's not zero, but it's also not, extremely high. But the difficult question is when to suspect bacterial superinfection, how to diagnose it, how to come to that conclusion. I agree with you. I think it's challenging. I guess I would say a couple of things. First, a couple of simple tests are blood and sputum cultures. If the sputum culture is growing Staph aureus and the patient has no other place, the Staphylococcus aureus is coming, and everything's in the lungs, you can think probably it's coming from the lungs. So blood and sputum cultures may be helpful. The other thing I would say is in the clinical course, let's say a patient is in the hospital, they're being treated for COVID, they're getting all the correct treatment, they're getting better, day by day they're getting better. And then suddenly one day they get high fever, WBC count goes up, they have sepsis, these things happen. Then I start thinking, okay, did something new happen to the patient? Some new infection, some new bacteria is causing problem now. Now I agree with you, it can be difficult to separate that problem from the problem of, is it just their COVID is worsening? So it can be challenging. And sometimes even I'm not 100% sure. And so when I'm not 100% sure, sometimes I will cover the patient with antibiotics because I don't want to make a mistake. Yes. But I guess my general concept is it's not necessarily needed for every patient as a default or as a reflex. So I would just think cautiously if the patient has what looks like classical COVID, meaning WBC count not that high, they have lymphopenia, they have, chest x-ray shows some peripheral scattered infiltrates, everything looks like COVID, then I don't usually give the patient antibiotics. But if they're in the hospital, suddenly they get worse, then I will think, okay, do I need to give, maybe they have developed a secondary bacterial pneumonia.
Yes, sir. But in the context of its presentation in India, maybe having a lot of infectious diseases as the as a possibilities. So I am interested in that difference. And secondly, when you are looking into the TC count, as you said, there will be a high TC count, and then people are already on steroids. And how do we approach? In fact, the study of the peripheral smear in conjunction with the total count is not a routine thing in India. And a few labs will be just giving out to look for the band forms, or the shift to the left, or the toxic granules. So to that extent, how would you subtract the elevation of the total count related to steroid and not due to the bacterial infection? Do you like to subtract an average of 5,000 count from the total, or any other means or proper guess? Thank you.
Yes, thank you, sir. Very, very good question, Dr. Fernandez. Okay, a couple of points. First, when the patient comes to the hospital, assuming they have not been given any steroids, before they're given any steroids, at that moment, the WBC count is very helpful, because maybe it won't be that high. Maybe they will have lymphopenia, meaning lymphocyte count is low relatively. To me, that suggests more COVID, compared to somebody who shows up to the hospital with white blood cell count of 18,000 or something like that. So that, is a little bit different. I'm talking about before the patient gets steroids. Okay. After the patient gets steroids, dexamethasone, you're exactly right. Steroids will cause a neutrophilic leukocytosis, meaning WBC count will be up, neutrophil count will be up, lymphocyte count will be down, and that can all be from steroids. So the problem is, suppose the patient has gotten 3, 4, 5 days of steroids. Now WBC count is 18, and it's mostly neutrophils, not much lymphocytes. Most of the time, that's due to steroids. Yeah. Now your question is, can you subtract 5,000 or 10,000 or something like that to attribute to the steroids? That's an excellent question, but there is to my knowledge, no data, no study, no evidence to suggest how much subtraction you can do. 5,000, 10,000, 15,000. Nobody knows that is a unanswered question. Nobody knows the answer to that question currently. So what I do is, after, let's say the patient has been in the hospital 5, 7 days, and white blood cell count is high now, 15, 20,000, something like that. It's basically, I consider it kind of unreliable, meaning I don't use it much in my thinking process for that patient. I much more go by the clinical status, meaning, do they have new tachycardia, tachypnea, new respiratory status is worse than it was. Now they're intubated, things like that. I don't rely so much on the white blood cell count when the patient is on steroids, because it's not reliable. I agree with you.
Thank you, sir. Okay. And in fact, the steroids are set to raise around 2,000 to 5,000. That's the question I have asked.
Yeah, maybe it could be that. I've also seen higher. I have seen that, raised to 15, 16,000, 20,000. So it's a little bit unpredictable, actually.
Yes. Thank you very much, sir. Thank you.
Thank you.
I'm not myself current on the comparison between dexamethasone and methylprednisolone. I believe there was one such study. Dr. Manoj is asking any data on the usage of methylprednisolone against COVID by itself.
Yeah, good question. I'm not too familiar with methylprednisolone. I'm more familiar with dexamethasone. However, if, for some reason in your hospital, you don't have dexamethasone, I would give the patient methylprednisolone, prednisone, anything you can have in the hospital, I would give the patient if you don't have dexamethasone. But in general, dexamethasone is preferred. I'm not too familiar with the other steroids.
Dr. Malampalli, it looks like you've been scanning the horizon. Did you look at that study where they compared dexamethasone with prednisone first 3 days and another 10 days, etc.? I recall that. Is there data comparing the two?
Yeah, I'm not familiar with that particular study. Maybe it came recently. I may have missed it, but I'm not familiar with that study.
Unmute yourself. Unmute your, yes.
Yeah, hi, Dr. Kulkarni, how are you? We've been using methylprednisolone here, and we went through a few studies here to compare, but I don't think there is like any good study, but the studies I could find was like one was around a couple of hundred patients, and then there was one is less than 100 patients. They said about both are similar effectiveness, so I guess it should be okay if patients can.
To help Dr. Manoj, dexamethasone is recommended. Dexamethasone has data. If you are using methylprednisolone, is it because of cost and availability, or is there some suggestion that it is equal? No.
Yeah, again, I mean, I don't, maybe Dr. Mallampalli can comment. I would go for dexamethasone if you have it. If it's not available, go for something else, prednisone, methylprednisolone, anything else. But if you have dexamethasone available and its cost is not an issue, that would be my preference.
Dr. Shekhar is asking, what is ROCM, sir? ROCM, associated cerebral edema. Can we use mannitol? I think he's referring to mucormycosis. Is that right, Dr. Chandrasekhar? Vijay Shekhar. Dr. Manoj, do you know the question? ROCM.
Yeah, ROCM is rhino
Sir, it is
orbital.
about it is about mucormycosis.
So
Right.
if you have associated cerebral edema, can we use mannitol?
Yes, I mean, from the infectious disease standpoint, it would be okay. I mean, we defer those questions to the neurosurgeons to give some advice on decreasing intracranial pressure. From infectious disease standpoint, it's okay, but usually we let the neurosurgeons make that decision.
Is there, Dr. Naveen has an interesting question. Can you mention a single absolute contraindication for steroids real time? I suppose you would say bad diabetes.
Well, I mean, bad diabetes, maybe not. I mean, if the patient's in DKA, meaning diabetic ketoacidosis, I might be a little bit careful until I got that under control. That would be one. The other one that people talk about is if the patient is having gastrointestinal hemorrhage, I might be a little bit hesitant to use steroids until that is cooled down a little bit. Those would probably be the main two. The other one is, for some reason, if somebody has an uncontrolled bacterial infection or something like that, I may wait a day or two until that's controlled to give steroids. But the main contraindications would be maybe diabetic ketoacidosis if you can't control it, or gastrointestinal hemorrhage. Those are usually the main two.
So Dr. Mallampalli, I don't know if you're helping us or asking a question. Comparing steroids, dexamethasone versus methylprednisolone. What's the conclusion in that study? Unmute.
Yeah, I mean, both of the studies showed methylprednisolone is comparable to dexamethasone. Like those are the studies I mentioned earlier. But I have a question for Dr. Kulkarni. So there was this, I had this question earlier also, like the last couple of days from somebody, and I answered what I know. But the question was baricitinib plus dexamethasone. And I did some literature search on that. And there was this study that I sent on the chart. It is a new study that is being published in the British Medical Journal. They saw like about 1,000 or more patients. And they said that there is some, it wasn't a statistically significant difference, but there was some predilection that it was actually helpful, that baricitinib with dexamethasone. I don't know if you have any comments on that.
Sure, I'm happy to comment on it, Dr. Mallampalli. Thanks for the question. Okay, so the original study that evaluated baricitinib again, baricitinib is a Janus kinase inhibitor, JAK inhibitor, was published in December in New England Journal of Medicine. And that study, original study, was remdesivir plus baricitinib versus remdesivir plus placebo. And in that study, the combination remdesivir plus baricitinib was in fact superior to remdesivir plus placebo. However, about 20% of the patients in that study received steroids. So it was a major confounder because they shouldn't have got, if they're getting steroids, then it's impossible to know what is the effect of what. So 20% of the patients got steroids. So after that study came out in December, the recommendations were to give remdesivir plus dexamethasone, only use baricitinib if you cannot use dexamethasone for the reasons we described earlier. As I showed in one of the slides, I went a little bit fast. As I showed in one of the slides, in April, just a few months ago, in the United States, there was a big trial going on, which was a very important trial. Remdesivir plus dexamethasone versus remdesivir plus baricitinib, meaning which combination is better for the patients, remdesivir plus dexamethasone or remdesivir plus baricitinib. And in fact, in middle of April 2021, that trial was stopped. It was cut prematurely because by pre-specified endpoints, it was not thought to be the case that, meaning when they evaluated the patients who had been enrolled in the trial by then, there had been no benefit from, or there was no difference in remdesivir plus dexamethasone versus remdesivir plus baricitinib. And in fact, dexamethasone is extremely cheap. Baricitinib is very expensive. So the combination of remdesivir plus dexamethasone was no different than remdesivir plus baricitinib. So for that reason, still currently the recommendation is not to use, or to use baricitinib only if the patient cannot take dexamethasone. The other thing, we have no trial that remdesivir plus dexamethasone plus baricitinib, all three together, we have no trial looking at that. Now, so that's kind of currently where we stand. Now, as far as this trial published in BMJ, I haven't seen it specifically. Maybe I need to check it. Maybe it came recently, but it sounds like it wasn't statistically significant anyway. So again, I guess my preference for hospitalized patients would be dexamethasone first, maybe remdesivir. And if the patient is getting much worse and about to go to the ICU, or maybe they just got in the ICU, that's a patient I would give one dose tocilizumab. So my main concept is always dexamethasone first, then remdesivir. And if patient is still getting worse, quickly give one dose tocilizumab.
Dr. Anne, I did not realize I was controlling the mute unmute. I thought Shivrao was. Only now I saw your messages. Please speak up.
No, that's okay, Dr. Kara. I just had one comment about the neutrophils and the steroids, and so the counts that we are noticing in COVID, the amount of the neutrophil cytosis is nothing, with steroids.
Can you get the microphone close to your mouth? Your microphone.
Yeah, right. Even the patients that are with the COVID have extremely high level of neutrophils, and it is not caused by the steroids. Steroids can cause probably 2,000-3,000, that which Dr. Kulkarni mentioned before. But we are seeing in COVID patients with steroids or without steroids, there is extremely high neutrophil count. Not only that, steroids can cause elevation of the neutrophils probably 1 or 2 days. It's mainly due to the demargination. But in COVID, we are having the cytokines which is causing the neutrophils release from the bone marrow, and it is extremely high level of the neutrophils. If you see, most of them, sometimes we see more than 20,000, 25,000, especially when your patient is admitted in the hospital. So that is nothing to do with the infection or nothing to do with the steroids. It is purely a viral response or cytokine response. That's my main comment on that.
Dr. Manoj is still asking any comments or research evidence available on doxycycline use in COVID-19. You, I believe, answered in the beginning, you're not routinely giving antibiotics unless upon admission you wanted to be sure that it's not a bacterial pneumonia. You might give it for 3 days, right?
Right. So basically for outpatients, I don't use antibiotics. And I specifically think doxycycline has not been evaluated. Azithromycin was evaluated in a randomized controlled trial. It was published in, I think, Lancet a few months back, showed no benefit for patients who were hospitalized with COVID. So bottom line is for outpatients, I don't routinely use antibiotics. I don't think doxycycline has been studied, to my knowledge, in a randomized controlled trial. And for inpatients, typically I don't use it up front at admission unless I have some reason to suspect a bacterial pneumonia. The time I tend to cover with antibiotics is after the patient has been admitted in the hospital a few days, they're sort of getting better, and now suddenly they get worse. Then I think, okay, did the patient get a secondary bacterial infection? Unless I have some reason up front at admission to suspect, I don't usually cover if I know the patient has COVID.
The comment regarding monoclonal antibodies, you already discussed it, but you might want to consider this question. Please discuss the dose, route of administration, and side effects of combination monoclonal antibodies.
Yeah. So route of administration right now is typically IV, intravenous. There was recently just in last 1 week, some people are talking about injection, intramuscular, I think, monoclonal antibody. I think we just discussed it in the United States within past 1 week. But typically it's one-time infusion, IV. There's no oral version of it. The main side effects are there's some small fraction that can have infusion reaction, meaning more like anaphylactic type of reaction. It is rare, but it's possible, and it has been seen. So that's the main side effects or main reaction that I would be concerned about. But again, the predominant route is IV. But again, I think in the last 1 week, there is a intramuscular one injection form of it. I don't know if it's available yet in India. Even in the United States, it's barely available. So, and I think it's very recent. So I don't know if that'll be coming soon.
With regard to all the other, with regard
I'm sorry,
to all
Dr. Kairam, I may add one of the issue about the reactions for the monoclonal antibodies is not due to the anaphylactic reaction. It is mainly the complement activation. When you add the monoclonal antibodies, antigen antibody reactions, which is a result in a complement rather than anaphylactic reaction, because these patients do not have any IgE antibodies against these monoclonal antibodies, because these are new antibodies. So it's mainly the anaphylactoid reactions where you can control with pre-treatment, or if they have reaction, can control easily with antihistamines and steroids. So that's not a major problem. And the other comment about the intramuscular rather than intramuscular, we see these monoclonal antibodies absorption is as good as IV if you're giving subcutaneous infusion. We do that, the monoclonal antibodies, not in this condition, in other conditions as subcu antibody infusions.
You could make sort of a final comment about all the other antiviral agents other than remdesivir early on. In India, many other antiviral agents have been used. Can you put closure on that matter?
Yeah, unfortunately, we don't have great data for other antiviral agents. There was a study at the very beginning of the pandemic in March of 2020, published in New England Journal, of lopinavir plus ritonavir. And that was a negative trial. It didn't show any benefit. Subsequently, the World Health Organization, WHO, did a large trial called the Solidarity Trial. And they studied 4 agents, one of which was remdesivir, another one was lopinavir, ritonavir. And again, there was no benefit in that trial. So that's the main one I'm familiar with. There have been some people looking at favipiravir and a few other things, but I don't think anything has panned out other than remdesivir. And somebody made a comment in the chat about doxycycline and its antiviral activity. That's a sort of theoretical possibility, but again, there's no clinical outcome data to support use of doxycycline at this point. It may have in vitro activity, but that doesn't necessarily translate to clinical outcome data.
If we were to stay within published guidelines, either from India or from here, there's no other antiviral agent in the list right now.
Not currently, no.
Okay. Dr. Mallampalli, if you promise to ask the question in short course, proceed.
Hi, Dr. Kulkarni. So I read a few articles on this antibody-mediated enhancement in COVID, especially in variants that don't respond to these monoclonal antibodies, or those variants that have the immune escape phenomena. So do you have any comment on that antibody-mediated enhancement of the infection? So people getting worse when they get monoclonal antibodies or post-vaccine infections?
Yeah, great question, Dr. Mallampalli. Thanks for asking. I think the phenomenon you're, of course, referring to is ADE, antibody-dependent enhancement. And the concept comes from production of non-neutralizing antibodies. So you have some antibodies, but they're not enough to neutralize the infection. And in fact, they can paradoxically allow for increased, viral entry via the Fc part of the antibody, and it can lead to worse outcomes. I mean, you all are more familiar than me, probably. One of the best examples of antibody-dependent enhancement is dengue. Can have an antibody-dependent enhancement on the second infection can be worse than the first infection because of these non-neutralizing antibodies. Now, with respect to COVID, I think there had been some concern that some of the vaccines, for example, could produce this phenomenon of ADE, antibody-dependent enhancement. To my knowledge, and somebody can correct me if I'm mistaken, to my knowledge, there has been no published literature or published even case series or description of true ADE, to my knowledge, from COVID, at least in a systematic way. Now, what I will say is, as many people know, there have been several documented cases of reinfection with COVID, meaning second infection with COVID. That has been documented. In some instances, the second infection has been milder, meaning less symptomatic. In some cases, the second infection has been worse than the first infection. Now, I don't know if in those cases, the reason for why it was worse had anything to do with antibody-dependent enhancement. Maybe. That's possible. I'm not 100% sure. There have been limited number of cases of reinfection as far as what's been documented and what we know. It's possible the prevalence of reinfection is higher than we believe because maybe we're not testing everybody and things like that. It's possible. But in general, the second infection overall has typically not been worse than the first. And so I have not seen widespread documentation of a problem of antibody-dependent enhancement, either from natural infection or the vaccines. I'm sure there are some isolated cases and anecdotes and case reports, but I haven't seen a large publication describing that phenomenon clinically.
Dr. Shekhar wanted to clarify the role of doxycycline, not as an antibiotic, but as an antiviral. Dr. Naveen is reminding everybody it has been removed from all protocols. Is that right? No doxycycline anymore.
No.
Yes? Dr. Kulkarni,
Yes,
we can forget doxycycline from now on.
For COVID, yes.
Yes.
at least for now. Again, I just want to emphasize, any of the things we discuss now, in 2 months, they may be slightly different as new evidence comes. So the point is, at least the philosophy is, whatever the current evidence is, that's the best evidence we have, and follow that. And if the evidence changes, we should also be flexible and change. So if we say no now, that's okay. Maybe in 2 months or 3 months, maybe a new phase 3 trial will come out and show some benefit of something. So we can always remain flexible, but try to stay within what we know currently, at least, right now what is effective.
You already addressed this, and also Dr. Anne made a comment a moment ago. In severe cases, surge in inflammatory markers with high counts in the second week. How to differentiate between ongoing viral and secondary bacterial infection? Its management awaiting culture report. Can we consider IL-6 inhibitors at this stage?
Yeah, so regarding how to distinguish between ongoing COVID inflammation and a secondary bacterial infection, I agree with you. It's very difficult. Sometimes you have to cover with antibiotics and you wait for blood culture, sputum culture, whatever other data you may have, you have to wait. And it can be very difficult. In terms of use of IL-6 inhibitor, again, we're talking about tocilizumab, basically. The time to use tocilizumab is patient comes to the hospital and is getting worse in the hospital, despite being on dexamethasone, maybe remdesivir. Despite that treatment and other supportive care, patient is still getting worse. And particularly, the oxygen requirement is going up. And there's evidence of inflammation, usually by CRP greater than 75 or 7.5, C-reactive protein being higher than that's the evidence of inflammation. So if they have evidence of inflammation, patient's getting worse, and oxygen requirement is going up, that's the moment I use tocilizumab for hospitalized patients. Some people, maybe you can consider use it up front at admission, maybe, depending what the history has been before the patient came. Usually, though, we wait, see how the first day goes and then give it. You may, if the patient is very sick, you may consider giving it on the first day.
You already discussed the route of administration of the monoclonal antibodies, but is there any ambiguity on the dose? Dr. Gopi is asking the dose of monoclonal antibodies. What's the recommended dose, or is there a variation?
Yeah, great question. This has been changing a little bit. I don't have it memorized. I usually check the website, to be very honest with you, because it changed a little bit. But I usually check the website because there are also so many different antibodies. There's like 4 different antibodies. So I have it memorized. It may be a little bit difficult. So if I'm going to give it, I usually check the dose and I follow whatever the US FDA guideline is for using it. But pretty much it's only one standard dose that everybody gets the same one standard dose.
Dr. Buddharazu has his hand up.
Yeah, I had a couple of, one is on that ADE. I think the FDA looked at the possibility of ADE with both the vaccinations as well as the monoclonal antibodies. At least with the BLAZE-1 study and the Regeneron study, they didn't find any evidence of ADE in that population, if I remember right. Number 2 is, there was a confusion in the dosing of bamlanivimab combination, the Lilly combination. The EUA issued was for 700 milligrams plus 1400 milligrams. But BLAZE-3 and BLAZE-4, I think, used much higher doses with no additional toxicity of, I think, 2800 milligrams. And the efficacy was actually better with the higher doses of bamlanivimab. As far as the Regeneron compound is concerned, I think the recommended dosage currently is 600 milligrams per 600 milligrams, the cocktail. So that's the answer to that question.
Dr. Mallampalli put those doses in the chat box for those of you who want to write it down or take a picture of. I think the questions in the chat box are almost done. Dr. Kulkarni, as these questions came up, and as you are fielding questions from Pune, you get consults from India, you talk to colleagues, and although the activity has subsided in India in the past 1 week, total number of cases have fallen, deaths are falling. What is your parting advice to this group? What should we be watching out for? Because in the past 1 month, there has been a lot of improper treatment. So I'm asking for some parting thoughts.
Thanks, Dr. Karam. Before I say that, I just wanted to say, well, a couple of points. One, I will send you my slides and please distribute to everybody on the chat. I hope they could be helpful to everybody. I also wanted to thank you again for the invitation to speak. I also wanted to thank Dr. Sudhakar and everybody else as well for the invitation. I really appreciate it. And also, I don't know if she's here, but Dr. Guntupalli, who's my colleague at, we're both a faculty at our institution. So I wanted to thank her as well for linking me with your group. So I'm very grateful to all of you to be able to, speak to you. As far as parting thoughts, my two main thoughts are the following. One is, I'm glad the situation is getting better. Still, the best and fastest way out of this is vaccination, which I know everybody knows that. But again, the faster we can get everybody vaccinated, the quicker we'll see the cases go down. Now, I know supply has been a little bit of a challenge, but I've been telling all of my own colleagues, relatives, everybody I know in India, any vaccine they can take to try to get vaccinated as quickly as possible. Whether it's Covishield, Covaxin, whatever is there, I would just try to take it, is my suggestion to folks. I know, there are some concerns. They're not maybe as efficacious as the mRNA vaccines, but when the pandemic is so bad, whatever vaccination we can get to people, I think is the best option. So many of my own relatives have taken Covishield or Covaxin vaccine. So that's the first point. Second point is, as we've discussed many times on this call, Dr. Kairam, to the extent that we can stay in the evidence, I think it's beneficial. Because we found, about 1 year ago in the pandemic, we were doing many things out of fear because we didn't know what to do. It was new virus, and we're all physicians. We don't want to see the patients having a bad outcome or dying or having any problems. But sometimes we may do things that we think is helpful, but maybe it turns out that it's not the case. The best example of this is hydroxychloroquine. Even in my own hospital, my own colleagues were giving many patients hydroxychloroquine back in March, April last year. And it turned out not to be the case. It turned out not to be effective therapy. So we may feel something is effective, but without evidence, we're just guessing. It may be yes, maybe no. And a single patient getting better doesn't prove that something is effective. You really need data. You need a trial. You need some larger group of patients rather than just one individual patient. So again, I think to the extent we can stay within the guidelines, I think it's generally helpful. Sometimes some patients fall out of the guidelines, but overall, if we stick with the evidence, I think that's the safest approach. Another example of that is full dose therapeutic anticoagulation. We were giving that even in my country, United States. We were giving a lot of therapeutic anticoagulation in March, April, May, and many patients died, and we thought we were doing the right thing. But subsequent trials showed that that was not the right thing. I mean, we made many mistakes in the United States as well. I think those are two good examples where we tried to do something and it wasn't necessarily beneficial. So I think to the extent we can stay within the guidelines and keep doing studies to figure out what works and what doesn't, that's probably the best approach. And you may say, well, we may be missing some things that we don't yet have the trial, but maybe they are effective. That may be true, but we don't know we don't know which ones those are. You don't know before you do the trial what's effective and what's not. So I think sticking with the evidence is probably the safest approach, and to try to get everybody vaccinated as quickly as possible. And I know everybody is doing a heroic job trying to do that, and I'm glad things are hopefully slowly getting a little bit better.
So stay within the guidelines, get vaccinated. Dr. Sudhakar, in case we don't have a meeting tomorrow, you might want to say a few things or whatever about vaccine status and the latest availability data for amphotericin.
Yeah, thank you, Dr. Kairam, for a wonderful session that we had. I wish to thank Dr. Kulkarni particularly for his very forceful presentation, the presentation with a lot of honesty and sharing his wisdom, and ready to share his slides also indicates that he wants to pass on the message to everybody, and everybody should be within the guidelines. Thank you very much, Dr. Kulkarni. And with regards to the mucormycosis, the situation, the drug situation is improving. It's not the amphotericin, but the posaconazole is available in quite a large quantity over here. So injectables are being given to the patients in the perioperative period and postoperative as well. So, so far, the drug crunch has come down a little bit because of the availability of the posaconazole. And the cases are rising, but at a steady pace, they're not exploding. So that way we're able to manage. So tomorrow, I think Dr. Prem Kumar might still come back. I'll check with him. If that is the case, we'll have a session tomorrow also. After that, probably tomorrow I will be making an announcement that we'll have on every Sunday morning, like we had previously. With this, we have completed almost 31 or 32 in a row every day. So we will go back to our weekly schedule starting from the next Sunday. So I'll check with Dr. Prem Kumar. If he confirms, so that will be the last in this particular series. But the experts that we have on the panel, we will be inviting them again to share their thoughts on the weekends. Thank you very much, Dr. Kairam, Dr. Pratik, all the experts who have pitched in today to share their experiences, and all those who have participated by asking questions. Thank you all.
So
Tomorrow, Prem Kumar sir will be joining, sir.
He will be. Okay. So we'll see you again all tomorrow night at same time. Good night. Pratik, thank you very much. You came in exactly unexpected, but just a savior of the night. Thank you.
Thank you, Dr. Kairam. Thank you all.
Bye-bye.
Thank you.